Hey, welcome everybody to another IMG VMR. So it's a pretty special day. I brought the entire Yale residency program here, internal medicine residency, with a really fantastic case that was shared with us maybe about 6 months ago now. Kanika and Ritu presented this at a morning report, and I told them afterward right away, you need to present this to Robbie and Reza sometime. So here we are, and I'm excited to introduce Yasmin and Deb to run the rest of the session.
Hello, everyone. Thank you for joining us today. We have another residency program, VMR. I'm so happy to be with Deb here. Hey, Deb.
Hi, everyone. Thank you so much, Andrew, for helping us to organize this session. We are really excited to have your team from Yale.
Yeah, and we can introduce our case presenters, Dr. Kanika Segal and Dr. Riturjit Rajakrishnan. Please correct me if I said it wrong. And good, thank you. Um, so they will be presenting a case to our dear RLR, our wizard and mathematician here. So can you please introduce yourself, Dr. Karika, and tell us more about yourself, what you like doing outside of medicine?
Hi everyone, my name is Kanika. I'm a PGY2 here at Yale. Outside of medicine, I love to work out. I love to draw and paint whenever I can, and read anything that is non-medicine related in my free time.
That's amazing. Deborah here, she also really likes working out. She made the whole CP Solvers Academy like workout and challenges. It was intense, but nobody won against Dr. Justip. And Dr. Ritujit, how about you?
Hi, everyone. I'm Ritajit, or Ritu, whatever is easier. I'm a PGY3 at Yale, and really excited to be here. Outside of medicine, honestly, a couple things that I do really well is eat a lot of good food. And so my wife and I currently are in pursuit for finding the best Indian food in Connecticut. So that's kind of been our go-to currently.
So far, which is your number one restaurant?
I don't know if I can give that plug on here. I'm not sponsored by that.
Okay.
But other than that, a lot of racket sports whenever possible. So tennis or pickleball has kind of been my recent thing.
Wow.
Thanks for having us.
We will be waiting for your review of restaurants. And now we will give the mic to Rissa and Ravi today. Ravi?
Hello. Good morning, everyone, or good noon, I should say. It's a thrill to see so many individuals here with the cameras on, but also the collective group at the conference room at Yale. It's really a privilege to meet you all, and thank you for sharing your lunch with us. I will share with you my VMR tradition, which used to be yogurt for many years, but if you're following closely, you should know that that's no longer true. It is now an upgrade to oats. But speaking of upgrades, I will pass the mic to my older, wiser, and more elegant brother, Prof. Rez.
Good morning, afternoon, evening. I'm very excited to dance with my brother Robbie, and a hello to all those Yale residents and everyone on VMR. And thank you, Andrew, Yaz, and Deborah for arranging this. Looking forward to discussing. And when you're in Lyon, France, you got to wear the scarf when you discuss the case. It's just mandatory.
Rafrez, I love that you just casually threw that he's hanging out in France and still making the time to join us here. That's a real treat. I think we have the co-hosts ready to actually, yes, maybe you can make oh no, you did. Awesome. All right. I think we're ready to rock and roll. Kanika and Ritu, we'll jump right into your case.
All right, awesome. We have a bunch of aliquots that Ritu and I will alternatingly present. So let's start off with the first aliquot for our case. This is a 26-year-old male who presents to the ED with persistent headache.
Facility alert.
Sorry.
Fire alarm activation, all clear, North Pavilion 3. Fire alarm activation, all clear, North Pavilion 3. Fire alarm activation, all clear.
Welcome to the. By the way, that used to happen all the time in the middle of the morning.
Sorry about that. But coming back to our patient, he came in a week after having a week-long history of persistent right-sided headache, along with some left-sided weakness that he experienced intermittently. And I will stop there.
I think if I start talking, I'll give Prof. Rez a headache. So why don't you kick it off, my friend?
You're far too kind. I think why don't we kick this one off together? Maybe I can comment on the headache, and then you can tackle the second part of the problem. Headache is something that we see frequently. It's almost similar to AKI in the hospital setting. And oftentimes, AKI, headache, diarrhea, on day one, they're just the victim or a bystander, meaning they're just part of that clinical syndrome, but aren't a clue to the ultimate diagnosis. In this case, it's different for a number of reasons, but primarily because the patient is coming with that chief concern of headache and has a red flag sign. What's a red flag sign? Intermittent weakness. But I can't talk too much about that red flag sign because I've already delegated that to my younger but wiser brother, Robbie. But let me give you a practical approach to headache, and then we'll use the weakness to apply it to this young patient. When you're approaching headache, you really want to view it in two buckets. Is it a primary headache syndrome, like migraine, tension, cluster? And that really is the base rate. And that's where you gotta seed yourself in, because most often it's one of those diagnoses. Or is it a secondary headache syndrome? And what makes us deviate from primary to secondary are those red flag signs, which we use the mnemonic SNOOP. I'm not sure who created that mnemonic, but it's extremely helpful. And it ultimately boils down to inflammation, like systemic symptoms, neurologic findings, onset that's sudden, or tempo that is a persistent headache. These are all concerning findings, and P can be postural. I don't know the exact mnemonic of SNOOP, but it's like inflammation, focal neurologic findings. Is it a postural headache? Is it new onset headache? Is it a persistent refractory headache? Once you identify a red flag, now you got to go into the secondary headache syndromes. I do have to tell you guys something. Migraine can have those red flags. Like migraine can present with a focal neurologic deficit. Migraine can do almost anything, but you don't want to just settle on migraine. You want to consider the secondary bucket. And the secondary bucket is very simple when it comes to headache. One, are you dealing with something intrinsic to the head? And there you can just take an anatomical approach. I want you all to imagine an arrow going through Robbie's head. This arrow, as it goes through Robbie's head, it can hit the parenchyma, it could hit the vessels, it could hit the meninges. So pathology at any of those sites, from meningitis, giant cell arteritis, venous sinus thrombosis, all of those can lead to secondary headache. So we have intrinsic, then just go extrinsic to the head. So stay with the head. So we're still above the neck. Extrinsic, you can have pathology of the eye. I once heard a story of a patient with sudden onset headache who ended up having glaucoma, sinus disease, dental pain, neck pain. All of this can manifest as headache because it's within this region. And then finally, once you went from intrinsic to extrinsic, go systemic. So systemic disease, whether it's an inflammatory process, can manifest as headache. So to summarize, this is a young patient. So far, it's a first-time headache. There's a focal neurologic deficit. We're in the secondary bucket. We've deviated from migraine, tension, headache, to, is there something happening within the brain and the central nervous system, or something extrinsic, or something systemic? And then I would love for Robbie to use the other clue to see where we might be able to localize the pathology.
Yeah, I think that's absolutely superb background and lays out essentially the comprehensive schema that we'll have to analyze today. And if you just happen to casually walk into this room while somebody else was getting a history and you heard the second part first, that you heard the patient has left-sided weakness, I think that you would realize that the value of the headache is tremendous because it helps you localize weakness to the brain. So I think that the concomitant presence of a headache and weakness helps you avoid an extensive differential diagnosis for where that weakness may be. And you'll notice that very few people will do the exercise of, oh, could this be in the core? Could this be in the nerves or the plexus when the head hurts at the same time? So you're making that leap of faith, especially when that leap of faith includes concordance of where the headache is and where the weakness is. So here the headache is on the right side and the weakness is on the left side, further strengthening the notion, since the brain crosses the midline, that these two things are related. So you don't have a localization exercise anymore, thankfully. It's really the question of what is in that right side of the supratentorium. The dimensions are very interesting, and there are two of them. The first is that this has been going on for a week, and that the second is that the weakness is intermittent, comes and goes. And I think both of those things are profoundly informative pieces of information. To reflect on subacute CNS syndromes are almost always space-occupying diseases. So the probability of imaging being positive here, even maybe a CT scan, is through the roof. If it's not space occupying, it's likely to be one of two other things, one of which is much more morbid than the other. The more morbid secondary consideration is a venous sinus thrombosis, and the less morbid acutely is demyelinating disease. So I think this information alone, subacute CNS disease equals space occupying, followed by venous sinus thrombosis, followed by demyelinating disease. Just with this information alone, you now can make tremendous progress with what kind of imaging modality you would get. We know this patient's going to get advanced imaging, but if you're sitting there asking yourself, oh, is a non-con CT going to be good enough? The answer is, if you change your order just a little bit and get a CTA and CTV with an extra 10 minutes in the scanner, you will have so much more information than a simple non-con head CT. So what's actionable with this diagnosis is I recognize the patient will probably end up getting an MRI, but it takes hours to get an MRI. The advantage of a CT with contrast in this situation to detect an enhancing space-occupying lesion, and more importantly, to detect or exclude the possibility of a dural sinus thrombosis, is very important. Intermittent. What does it mean when something is intermittent? This is a long conversation, but I hope you'll trust me. Intermittent diseases are a subcategory of sudden diseases. For something to be intermittent, it usually starts abruptly and ends abruptly. And so if you can borrow from the CP Solver sudden filter of obstruction, rupture, and discharge of electrical activity being the most common, you start to generate hypotheses about how this process may represent occlusion, rupture, or discharge of electrical activity. It's hard to reconcile rupture with what's going on now since it comes and goes, but you can easily imagine a progressive space-occupying lesion that intermittently causes seizures, for example. That's probably the reflex hypothesis whenever you have transient CNS diseases. Of course, it could be a transient vascular phenomenon like a TIA or a vasospasm. If you're filtering headache through this, it's unlikely for a TIA to cause a headache. So Prof. the other parallel symptom is juicier than the headache, I would say, in large part because the headache just helps you focus on right-sided brain issues. Tempo means space-occupying venous sinus thrombosis or demyelinating disease. Intermittent, worry about seizure, but also worry about the possibility of vasospasm in this context. Few words, but a lot of information can be gleaned from it, I think. So thank you for setting us up for this conversation. I'll pass the mic to you for more.
Yeah, honestly, we're so blown away by how much you've taken away from the one sentence that we've given you so far. So much learning getting to see this case through your lens today. So thank you so much for that. We're going to give you a little bit more information about the headache and a little bit more about his past medical history. He generally felt well prior to presentation. His headache was primarily right-sided and did not have any specific triggers or prodromal symptoms, and it resolved by itself. And that left-sided weakness that he had was not always associated with the headache and also resolved by itself. He had no tingling or numbness. Overall, his review systems were negative. His other medical history was remarkable for him, moving from India in 2019 and currently working as a software engineer. He had a past medical history of a splenectomy at the age of 3 for an unknown reason. And he also had a prior history of TB lymphadenitis in 2019. He was treated with RIPE for 12 months. He also had a recent URI that was treated with Augmentin. Otherwise, he takes no medications, has no allergies, and no other significant or related family medical history.
I'll just Prof has left me the juicier aspect, so I'll actually do the same this time and just reflect on what value there is of him being a software engineer. I think whenever you're dealing with and trying to understand a specific diagnostic space, you both want to understand how the disease process evolved over time, and you've been kind enough to give us that. You told us that the headache and the weakness evolved over a week or so and is coming and going. But I think knowing where you start is so important. And I think inferring from the fact that his cognitive capacity was robust enough for him to be a software engineer allows you to make the formulation that this likely CNS disease process is very strong and very, very penetrant, because it's taking somebody with likely very strong cognitive reserve and making them really vulnerable and really symptomatic, albeit in a very sneaky way. So I love that rich social history. Of course, it's equally rich to reflect on the fact that he's coming from India, which might be information that you use to your advantage should the syndrome become more relevant to considering things that might be epidemiologically linked. But right now, I think it's too soon to speculate. All right, Prof. Rez, I'll pass the mic to you for everything else.
Yes, and I want to say thank you for the manner in which you're presenting the information. You're really setting it up for an excellent discussion. And this just shows you how powerful the background information is in analyzing the foreground problem. Because the splenectomy means that this patient is immunocompromised. And it doesn't mean that at the end of this case that we're going to find an infectious etiology, not at all. But it just broadens our differential diagnosis, and it makes us pay close attention to what types of organisms such individuals who don't have a spleen might be at risk of. If you all remember, the spleen is a secondary lymphoid organ, and its involvement in the immune system is when we opsonize bacteria with immunoglobulins, the macrophages in the spleen, they take a bite out of those bacteria. We commonly think of encapsulated organisms, so it's going to be really important to know, did this patient have their prior immunization or not? And these encapsulated organisms include H. influenza, Neisseria, S. pneumo, but it's not just encapsulated organisms. Robbie, do you remember that case in Baltimore that I had? It was a patient who had sickle cell disease. He had auto-infarcted his spleen, and he was getting blood transfusions every so often, and he had a fever for a week, and no one could figure out why he had a fever. And Robbie and I did our residency at UCSF, and I remember sitting in Morning Report and Harry Hollander, our program director, saying patients who have splenectomies are at risk of babesiosis, severe babesiosis. And we ended up sending the thick and thin smear. I actually sent it because I thought of Harry. And then the ID attending was like, who sent that? Which hospital has sent that? But in any case, you just got to recognize two things with the splenectomy. one, infection, and we can talk about CNS infections if it becomes relevant based on the imaging. For example, if we have an abscess or a mass that's enhancing. And two, this patient may not manifest symptoms like someone with a competent immune system because the spleen is not there. So we have to even have a lower threshold to prioritize infectious etiologies. But recognize the spleen not being there may have no relevance at all to the final diagnosis. So just be cautious. So we're tracking that information. The prior TB, TB is so common worldwide, meaning I think about 2 billion of the world population have latent tuberculosis. In fact, I'm from Iran. I had latent tuberculosis and was on isoniazid for 9 months. I'll share that story another time. But let's just say my urine turned orange because they didn't prescribe me vitamin B6, but they prescribed me Peridion by mistake. And I never went and saw that primary care doctor again. I fired them. But once you have TB, could this be a recurrence of TB? And could there be a tuberculoma? Absolutely. The one question I'm really interested in, and I would love to hear from you, you mentioned that there's no triggering factors, but there's one question that I think would be really helpful, and one that I would ask this patient, is that whether the headache was worse in the morning. Because a lot of these mass occupying lesions, because when you take away the effect of gravity and you're lying supine, all of a sudden you increase the pressure in the head and the headache is worse. And that's why headache worse in the morning is another red flag, and it should make you think of a space occupying mass. So I'm just curious to know that if you ask that question.
Thank you for that question. And honestly, when we admitted him, we did take a deep dive into his headache history, and he really had nothing that was significantly positive. He definitely said that his headache came on at random times, wasn't really associated with being more in the day or later towards the day or even at night. Never said that it woke him up from his sleep. So that piece of history was essentially negative.
Beautiful. Robbie, anything else you want to comment on before we get some more data?
No, I'm just so excited for the exam because I think that you're really trying to understand what the signature of this disease is right in front of you, because it seems to be hard to grasp. The headache is coming and going, the weakness is coming and going. So, and also we don't know why he had a splenectomy. We don't know if he got his vaccinations afterwards. So I think that the strength of the land that we stand on is not very strong. And I wouldn't be surprised if I fall through the cracks and you save me. And I'm really excited to see what I can take for what I can really lean on versus I think cautiously speculate with everything so far.
Okay, I can probably go ahead and give you his vitals and his initial exam. So his initial vitals were largely unremarkable: normal temperature, normal blood pressure. He was satting very well on air. For his head-to-toe exam, this was notable for a 2-centimeter bilateral anterior cervical lymphadenopathy. His lungs were clear to auscultation bilaterally. His heart was regular rate and rhythm, no additional sounds of murmurs, rubs, or gallops. His abdomen was soft, non-tender, non-distended. You could see the prior surgical scar from the splenectomy. His neuro exam was notable for intact cranial nerves, 5 out of 5 strength and sensation in bilateral upper and lower extremities. But on extremity exam, this was notable for bilateral firm inguinal lymphadenopathy, measuring about 2 centimeters.
This is a very helpful exam, and I want to applaud you. I often end up palpating the lymph nodes after the CT scan shows the lymphadenopathy. So it's really great that you guys were able to detect them earlier. And I just have to say one thing, like the way I do a neuro exam, I basically just touch the skin, and if they can feel it, I'm like sensory system intact. I have them pull me in. If they can pull me, I'm like motor strength 5 out of 5. It just, you have to realize like our exam is insensitive for picking up subtle weakness or subtle sensory deficits. And ultimately, and I use a stethoscope as my reflex hammer. I'm doing basically, hopefully no neurologist is listening to this talk. They're like, how does he have an MD degree? maybe Robbie, I want to do something with you on this one. I'm going to talk about localized lymphadenopathy, though I know this is not that, just to make a quick teaching point, and then I want to give you the mic for the diffuse lymphadenopathy. And if you just had cervical lymphadenopathy, I recently learned this and it like excited me. It made sense because I've always heard that if it's posterior lymphadenopathy, it's more concerning than anterior cervical lymphadenopathy. And now I know why. Because with anterior cervical lymphadenopathy, think about it. It's so close to the oral pharynx, and all of us are at risk of viral URIs or bacterial pharyngitis. And so when these lymph nodes are enlarged, oftentimes it's secondary to a local oropharyngeal infection. But the posterior cervical lymph node is further back. So when that is enlarged, it's often included to a systemic process like an infectious mononucleosis. I just thought that was a really cool pearl that I learned. And just, I always like to emphasize why, like when people say stuff, why do they say it rather than just memorize it? So I'm going to pass the mic to Robbie, and there's just the posterior cervical lymph node, the supraclavicular lymph node. These are very, and the epitrochlear, they're almost always indicative of pathology.
Super, Prof. Rez. I think that the landscape that Prof. Rez is outlining of localized lymphadenopathy is way more common than when it's disseminated. Because a localized process often reflects a local issue, either a local infection or a local cancer, as you just implied. A disseminated process means that this is a disseminated lymphadenopathy often means a disseminated process. Now, what is the nature of that process? It's almost always a disseminated inflammatory disease process. If you take base rate of all the kinds of inflammation, which we have reviewed many times on VMR, IMADE, infection, malignancy, autoimmune, drugs, and endocrinopathy, the two leading causes of lymphadenopathy in terms of inflammation are infection and cancer, by far and away. But let me, instead of giving you a comprehensive approach or sharing with you what I use as a sort of comprehensive approach of lymphadenopathy, I'll tell you there's a very powerful clue. The problem representation of this patient is not the following. A 26-year-old man who presents with 1 week of dynamic headache and left-sided intermittent weakness found to have large disseminated lymphadenopathy. That's not an accurate problem representation. What's missing? What's missing is the very marked pertinent negative. Ask yourself, what is the pertinent negative here? This person probably has over 10 centimeters of lymphadenopathy. Add all these 2-centimeter loads, and there's not 1 ounce of fevers, not 1 ounce of weight loss. This amount of lymph node activation is incredibly out of proportion to the consequences of this inflammation. Is this TB just kind of sneaking up in the lymph nodes, but leaving the patient otherwise functioning as a software engineer? Intriguing to speculate on that because he's had TB in the past. But now, Prof. Rez, I am stunned because I did not expect a 26-year-old, presumably otherwise healthy person to have pounds of lymph nodes.
Can I just make one interaction? Please
Yes,
don't
sure.
say it can't be TB.
Yes, I know.
Take that back, my friend. Please take it back.
I didn't say, I said, yeah, no, it's always a big mistake to say it can't be TB. I completely agree with you, Prof. Rez, but would I be shocked? Yes. I would be very, very shocked. So I think that you can ask yourself and try to make this schema as you go through in your head is, what causes disproportionate lymphadenopathy? And I think that the answer to this case probably involves that unless we realize that the history is not adequately capturing the disease burden that this patient has. So if we see that his white count is 35 and that his ESR is super high or he's got significant kidney compromise, we have yet to take a full inventory of whether this is truly disproportionate lymphadenopathy, but so far it's very suggestive of it. So I think it'll be very helpful to track that. Since I didn't really share any practical tips about disseminated lymphadenopathy, I'll tell you that you need to get 2 tests in every patient with disseminated lymphadenopathy, no matter what. And those 2 tests are an HIV and a syphilis every single time. So before we hem and haw about what this might be, make sure you order that HIV test and that syphilis. And I'll leave it at that for now. The next steps would be getting a sense of the impact of this immune activation on the patient with basic labs, and then reformulating our hypotheses about how we can make progress going forward. All right, Mike, back to you guys.
All right. Thank you for that. Honestly, it's so fun hearing you go through this case. We'll give you a little bit more information kind of in the order that we were getting it at this time as well. And so the next set of things that we'll share with you are the labs that we had gotten from the ED and his initial imaging. So his lab work was remarkable for a normal CBC and a normal diff, with a normal white count and a normal hemoglobin. The only abnormality was a platelet count of 703. He had normal electrolytes and creatinine, and his LFTs were also normal, except his PTT in his coag panel was elevated to 56. His CRP was 7.3. That's the lab work that we had gotten initially. The imaging that we had gotten in the ED was a CT head that didn't show any acute intracranial pathology, a CT sinus that showed an acute on chronic sinusitis, and an abnormal chest x-ray that led to a CT chest, which showed a 4 by 5 centimeter mass with mediastinal lymphadenopathy, some of which was calcified. This also prompted a CT abdomen pelvis that was only remarkable for inguinal lymphadenopathy, but otherwise normal.
And the position of the mass was in the left lower lobe of the lung.
Very, very intriguing. So to summarize, I think that maybe, Parfaz, I can reflect on the labs and then pass the mic to you to discuss the very intriguing imaging. And I think that if we just sort of answer that basic question that we tried to answer before, is what is the weight of this disease on the patient's laboratory data? And I would say it's overall underwhelming. Not overall underwhelming in total, but overall underwhelming to the degree of lymphadenopathy. And so my mind is still representing this as a disproportionate disease with lymphadenopathy, though you may temper that enthusiasm of a purely disproportionate disease because you see the platelets are activated, you were intrigued by coagulopathy, but truthfully, a CRP of 7.3 and no signs of anemia. And I would really invest in the fact that this person's not anemic whatsoever. Is a very, very intriguing dimension of this case. What's the value of thrombocytosis here? I think that it's interesting because if you take all comers with thrombocytosis, the vast majority of patients have reactive thrombocytosis, meaning that they do not have a primary hematological issue. A chronic infection, very possible here. A chronic malignancy, very possible here. Or an autoimmune disease, very possible here. But the clue, actually, I should say this, what often accompanies patients with thrombocytosis that is reactive in nature is an anemia of chronic inflammation and marked elevation in inflammatory markers. So while primary hematological diseases only account for a small fraction of thrombocytosis, the normal hemoglobin here and the relatively underwhelming CRP make that 10% into a much higher number. Probably not a number higher than the reactive category because the odds from the beginning are so stacked against it. But certainly that number in my mind is taking up more space than a mere 10%. The other clue here is the PTT elevation. And before I reflect on that, I'll just share the teaching point that it's really important to know what kind of coagulopathy you're solving before you solve it. So you want to know, is it an isolated PTT or is it PTT in conjunction with PT elevation? And I think I missed that part. So would just love for y'all to clarify, was the PTT the only abnormality here?
Yes, that's right. PTT was the only abnormality.
Very, very intriguing. Most often, this is a distractor, and it's a distractor because of a collection artifact with the tubes contaminated by heparin. And so the first step you want to do is to make sure that this is a true abnormality, not a laboratory artifact. But if you're trying to understand an isolated or disproportionate PTT elevation, you just have to go back to the factors that are involved in PTT and not PT. And those are 8, 9, 11. I'm missing one. 8, 9, 11, and phospholipids are the 3 primary factors, and also thinking about factors in the common pathway, factors 10, 5, and 2. So any abnormality you can think of in this pathway factors 8, 9, 11, 10, 5, 2, and thinking about phospholipids. All of those are totally at play. What would be a next step to understand the PTT is to, one, verify its persistence, but also to see if you can correct it with a mixing study. If you can correct it with a mixing study, it's much more likely to be a deficiency in something, in one of those factors. And then we would proceed to localizing which factor is deficient. If it does not fix with a mixing study, you're in a very fascinating situation where you have an antibody present. So I'll leave it at that for now. The key next steps are, is it heparin? And if it's not heparin, does it vanish when we put normal blood in? And that's how I would do to try to get more juice out of this interesting coagulopathy. But the imaging, oh my gosh, Prof. Rez, what are you thinking?
I love that, Robbie. I wanted to just ask a quick clarification question. The CT head, it was with contrast or without? No contrast.
Without contrast, yes.
And then the chest X-ray, how large was this mass in the left lower lobe?
4 by 5 centimeters.
So pretty large. I do have to say that you guys are, you can tell that Yale is a pro, and I'm not just saying this because it's Yale that's doing this. I know you guys have a great tradition of morning report, because I've worked with a lot of people from Yale, like Jake Applebaum, but you guys probably don't know who that is. He graduated many years ago. We're aging, you know, I can't just throw out a name and expect you to know who it is, but I loved how you included the diff and all the information that you gave us. The reason I asked about the CT scan is because what did this patient come to the hospital with? The patient didn't come in the hospital with pulmonary symptoms or lymph node enlargement. They came to the hospital with headache that correlated with the exact, weakness site that you would expect if there was a mass in that region. It is true that a non-con CT would show us a very large mass, but is it the perfect study to rule out pathology within the brain parenchyma, the meninges, or the venous? The answer is no. And now that I have the mass in the lung, what I really want is an MRI, MRV of the brain to see, am I solving a pulmonary CNS clinical syndrome, or is it an isolated pulmonary syndrome? The other thing I'll say is, when someone has a hemoglobin that's 9 or a creatinine that's 1.2, the first thing you do is say, what was the hemoglobin a week ago? What was that creatinine a week ago? The same applies to lung masses. It would be so helpful to know what was the prior chest X-ray. This patient had a history of TB lymphadenitis. Did he ever have a scan of the chest? And is there a delta between the prior imaging and what we're seeing today? And the truth is, sometimes we don't know that answer. But what I do know is I would not expect adequately treated TB to persist this large years later. It should have been completely eradicated. So now our center of gravity, borrowing from Robbie's beautiful term that he created that we all use, the center of gravity is the lungs. Meaning, yes, there's lymph nodes elsewhere, but right now in my mind, the primary site of pathology is the lung, and it's this mass. The calcification can be a clue to what kind of mass it might be, though you have to temper that by knowing the background of TB. It's a granulomatous process. Usually when we see calcifications, we think of granulomas. And this is the one instance where you would say, hey, radiologist, was there any calcifications in the spleen or not? Because that can be a strong clue to tuberculosis. So now the question is, what can cause a lung mass? It can be lung cancer. Young patients can have lung cancer. Young patients who don't smoke can have lung cancer, specifically adenocarcinoma. In general, lung cancer is broken up into small cell and non-small cell. I'll just leave it at that. And small cell has a tropism for the brain. So I think an MRI is really important. So cancer is one possibility. Another possibility is lymphoma. But you might say, wait a minute, but the platelet count is elevated. There is no B symptoms, as Robbie mentioned. How could this be a lymphoma? I think we just have to be very cautious by interpreting all the findings in the context of a splenectomy. For example, with the spleen removed, you're not going to be taking up the platelets like you usually would. Like my spleen, hopefully all our spleens have some platelets in it. So after splenectomy, you actually have a thrombocytosis. It's usually for months, but I would be curious, what was the prior platelet count? So it's really hard for me to interpret a lot of the findings in the context of the splenectomy. So lymphoma is a possibility. We talked about granulomatous infections, particularly TB and their cousins, endemic mycoses. So you can have a tuberculoma, you can have a histoplasmoma, you can have any fungoma. Just add an oma in it and you will be right. Additionally, GPA. GPA can cause a mass-like lesion, but we're not getting much clue for GPA in this case. And sarcoidosis, but sarcoid, yes, it can cause lymphadenopathy and it can cause mass lesions, but boy, this would be an odd manifestation. So the question becomes, where do we go from here? We're going to send serology to try to see if something comes back positive. We'll send an HIV, we'll send an LDH level, we'll probably send the fungal studies, we'll probably go after a BAL potentially, but ultimately this may come down to getting the node. And in getting the node, you have a good node right there in the inguinal region. So you might have to do an excisional lymph node biopsy or at least a core lymph node biopsy. But you really got to challenge yourself and say, can I get it to an answer without any procedure? There are cases of lymphadenopathy that you can. Robbie said HIV, infectious mononucleosis, lupus, Sjogren's, syphilis. You'll send all those, but it's hard to explain a mass in the lung with those studies. So what I would do next, MRI of the brain, working this patient up for atypical infections, trying to sample the material from the lung, and then considering a core or excisional lymph node biopsy. But the next series of data will help guide us.
Well, I think we lost your audio again, like before. I'm sorry, unless it's me. Ooh. Sorry.
And if you were applauding us, we want you to repeat it because we didn't hear it.
Can you hear us? Okay, sorry about that.
Now, yeah.
So I was just saying that thank you for walking us through all of that. I think it's been pretty comprehensive, and I think our thought process was pretty similar to everything that you just addressed. But honestly, this patient's clinical course changed so rapidly, which I will reveal to you, and maybe that'll change the picture a little bit going forward. So even before we could pursue any of the further workup that you mentioned, his hospital course was very quickly complicated by worsening right-sided headache, a new left-sided weakness on exam, where there was progression to left-sided facial droop, slurred speech, left arm plagia that resulted in multiple stroke codes. Repeated CT head from the stroke codes was normal. However, an MRI brain revealed acute infarcts over the left cerebral hemisphere, along with enlarged bilateral parotid glands. A CTA then revealed a large right ICA thrombus and cervical lymphadenopathy. A little bit of a twist in the tail.
This is extremely juicy, and I'm going to pass the mic to Robbie because I just spoke for hours about a lung mass. But Mike, to you, my friend, happy to dance with you.
Oh my gosh, Prof. Rez, I think you're the way you dissected the lung mass and all its relevance was so key. And I think it's unfortunate that this case has evolved in a more hectic way. And I think that the hectic way it's evolved is it really has a prominent vascular imprint. And that vascular imprint, unfortunately, has resulted in strokes on the left side, on the right side of the brain and the left side of the body. And the source of that seems to be a large ICA thrombus. And so I think we would probably be assuming that this internal carotid thrombus is the source of everything. There's a small chance that it embolized from somewhere else. But regardless, I think that we would probably be deploying our schema for what causes in situ thrombosis. And the vast majority of cases of in-situ thrombosis represent atherosclerotic disease, which is unlikely as a leading hypothesis in an otherwise healthy 26-year-old person. And so you might ask yourself, well, what else happens to blood vessels, and be systematic about it and ask yourself, just like atherosclerosis, is there something wrong with the blood vessel wall? And in somebody who has a systemic syndrome of immune activation, do you wonder, is there a vasculitis going on? Is there a vasculopathy? Is there a focal dissection that we didn't quite appreciate on the initial imaging? And if it isn't the blood vessel structurally, is there a dissolved hypercoagulable condition here? And when we go back and we see that PTT elevation, and we ask ourselves, wait, hold on, we thought this person was going to be at risk of bleeding, but here they are having massive thromboses. And that initially will cause a little bit of a head twist till you latch on to that final word, factor 8, 9, 11, 10, 5, 2, and phospholipids. The combination of a thrombosis in the setting of an elevated PTT should really make you wonder about the possibility of APLS, again, a dissolved hypercoagulable factor. The context here is very, very intriguing. Why would this person develop this syndrome? Most APLS is idiopathic, but it often can be secondary to autoimmune disease, and the most common autoimmune disease described is lupus, but there are others. So to summarize, I think you now have this probably subacute hematological syndrome. The hematological syndrome defined as lymphadenopathy, thrombocytosis, along with a mass, and now what looks like either a focal wall issue of the internal carotid artery, but more likely a hypercoagulable condition. And in the context of the PTT elevation, the most worrisome hypothesis would be the development of APLS. And so I think that, yeah, actually, maybe I just leave it at that, Prof. Rez, and see what you're thinking, what other thoughts cross your mind as well.
I absolutely love that approach. Nada.
I'm sorry, we lost your audio again. I'm not sure what happened. I'll let you know when it comes back.
Can you hear us now?
Yeah,
Oh,
yeah, now it's good now. Thank you.
sorry about the glitch.
All right.
That's okay, it's all good.
We are at our final aliquot now, before the final diagnosis. And it sounds like you're getting warmer and warmer, but I don't want to say more than that.
I'm actually getting colder and colder. Dude, they got to heat up this room. What the heck?
He underwent further lab work, including an AFP sputum that was negative ×3, along with negative PCR testing as well. He was HIV negative, histo negative. He had normal C3 and C4, normal IgG and IgE. He had an an ANA, for which the titers were 1 to 320 and 1 to 640. It was tested twice with a homogeneous pattern. But the reflex was negative for RNP, anti-SSA and anti-SSB, Smith antibody, and double-strand DNA antibody. ACE was also tested for, that was negative. Beta-2 microglobulin were also negative, both IgG and IgM, and cardiolipin, IgG and IgM were also negative. A lupus anticoagulant antibody was tested, and that returned positive.
Prof. Rez, I babbled away. What do you think?
So this is very intriguing. I will say,
Prof.
when we were
Rez,
talking,
sorry to interrupt you. I think I just saw from the chat that our friends had more information to share, but I think their audio cut out.
I don't know
Hopefully
what's
we're back.
Yeah, I don't know what's the last thing that you heard. The
We
lupus
heard
you were
anticoagulant
about to give us a diagnosis.
the last thing we heard was the lupus anticoagulant is positive. That's the last part. I think we lost you again.
Okay.
Can you hear us now?
Yeah, we can hear you now. Yep.
Okay.
The final thing that we had to add was that at this point we found records from India. And we had seen that he was positive for lupus anticoagulant 2 years ago as well, and that he had a prior ANA positive 1 to 1280 as well.
We're done
Oh,
talking.
Oh, okay, you guys are done. Okay. So this is really intriguing case. And the one thing, Robbie, that I'm having difficulty explaining is this lung mass. I think the thromboses, the elevated PTT, the persistence of the lupus anticoagulant makes a very strong case for APLS, and not just antiphospholipid syndrome, but catastrophic antiphospholipid syndrome, the way this patient is presenting. And when you do have APLS, as Robbie mentioned, lupus is the most common autoimmune condition associated with it. And in this patient who has had a persistently positive ANA, that's quite a good screening test for lupus. It's not specific. You wonder, could this, in fact, be lupus? If you look at the SLIC criteria, right now he's not really meeting the SLIC criteria, but I think it's so important to send a UA in this patient, to send a spot protein to creatinine ratio, to just see if there's kidney involvement, because you can make the diagnosis of lupus just purely on kidney involvement. And sometimes the APLS may precede the other findings of systemic lupus erythematosus. So I think right now we have a confirmed case of antiphospholipid syndrome. And bravo to you guys for getting the prior antibodies of the lupus anticoagulant. The question that remains is what's causing the lung mass? I could even explain the lymphadenopathy and say, hey, lupus and lymphadenopathy and APLS. So, Robbie, that's where I am at a bit of a loss and would love to hear what your thoughts are with regard to reconciling that. One, if you agree with APLS, and then two, what would the lung mass potentially represent?
I completely agree with you. I think you articulated it so well, Prof. I have nothing to add, honestly, and apart from just speculating. And the truth is that this person, I think, meets criteria for APLS is persistent positivity and a thrombosis. And what they have underlying is very, very intriguing. The positivity of the ANA, along with the oligosymptomatic nature of the lymphadenopathy, very much supports the notion of an autoimmune disease, but I have no idea what to do with that mass. I think the fact that it's calcified means it's been there for a long time. And the fact that it's been there for a long time makes me wonder and start to speculate, is it an old organized thrombus, or was there bleeding in the lungs that was then coalesced and organized? But I think if you remove that from this case, you have disseminated lymphadenopathy, you have APLS, and lymphadenopathy is long-standing. I think it makes a strong case for either an evolving autoimmune disease or one that's not fully characterized. But I think the practical question is, would you sample this mass? And I think my answer would be yes, despite the exceedingly complex conversations around anticoagulation and sampling that would have to happen in this patient. Because I think the company we talk about lupus keeping is the company we talk about APLS keeping is lupus, but it could easily be another autoimmune disease. So I don't know. I've never seen this before. I have no like confident associations, but I would be leaning on experts to really discuss the key matter, which is, do you sample this or not? Yeah, that's where I'm at. Any other thoughts you want to add before we learn from this amazing group?
No, I just want to say, I just love listening to you speak medicine, like the oligo something syndrome. Like it's just, you're just have a way with
Made up,
words.
man. It's all made up.
It's so good, man. I think if you're able to look at prior imaging from India or just talk to someone, say, hey, was this mass there? And then maybe even getting a PET CT to see if this is an active, metabolically active before going to sample it. But I'm right there with you, Robbie. Just trying to get as much information as possible before, doing the procedure.
Oh, by the way, Prof. Raz, I just saw that that Andrew tagged us and asked if which was an important observation on the CT scan, the bilateral parotid swelling, which I think is kind of surprising in a 26-year-old. um, if that is part of the calculus. I think it should be, honestly. I think I overlooked that. So I should just stop talking because I just did. I'm curious, Prof. Fred, does that do anything for you, or how are you
So I
incorporating?
saw that comment, and all I can associate with parotid swelling is either a stone or mumps. After those two things, I saw the comment, and I know it's probably important and will mean something, but
Yeah.
at this moment, I'm taking the Fifth Amendment.
I just add that it's helpful that it's bilateral. Bilateral parotid swelling is either metabolic, viral, or autoimmune. It's unlikely to be cancer when it's bilateral. It's unlikely to be just one single stone. And so I think when we keep saying autoimmune, autoimmune, autoimmune this whole time, I think what does the parotid swelling add? It adds the possibility of Sjogren's, sarcoid, IgG4 disease, and GPA. And I think I can't quite see a fingerprint. Like I think IgG4 disease is very rare in young people. GPA is much more hectic, though the thrombotic nature of this is certainly intriguing. Sarcoid is very possible. I think, and Prof. Rez alluded to it earlier. It can form masses. This person has lymphadenopathy. And then I would just say that the SSA and SSB are not sensitive enough to exclude Sjogren. So I think to answer your question directly, Andrew, I think it just reinforces the autoimmune vibe that this case has. And of the indolent diseases, I think that Sjogren's and sarcoid would get a little bit more of a boost from that, but I don't associate sarcoid as much with APLS. I imagine Sjogren's being a cousin of lupus probably is, but I don't know that to be sure. So that's my take on it. All right, guys, enlighten us, please. This is such
Okay. All right. So I think we were just as confused with the lymphadenopathy and the mass, just as you guys have alluded to. And we did bite the bullet. He did get a bronchoscopy that was negative for AFB. However, biopsy of that left lower lobe mass revealed acute inflammation and epithelioid histiocytes, some demonstrating imperiolosis, confirming Rosai-Dorfman disease. So eventually he had a concurrent diagnosis of Rosai-Dorfman disease along with antiphospholipid syndrome, as evidenced by his lab work. So, all in all, he was treated with warfarin as well as with aspirin. He was also preemptively started on hydroxychloroquine for SLE, given the high ANA titers, and then also given his young age. This was thought to be more preventative of further organ damage, also for being protective of further flares or even a progression of disease.
Unbelievably cool. This is such a great diagnosis, a very good outcome for the patient to land in your lap and not have a malignancy or something very, very scary. I'm ultimately not surprised by the answer because Rosai-Dorfman can be so sneaky and so indolent and take forever to get diagnosed. But I'm glad it was you guys taking care of him and not me, because I probably would have overlooked it. Prof. Rez, what are you thinking?
I am just, I want to thank you for presenting such an interesting case. And in doing my cognitive autopsy, like ultimately, probably 90% of the time, your final diagnosis has to explain the initial chief concern of the patient. And here, that right-sided headache was a clue to that there was some kind of pathology there. And I think with the spleen removed, being open to multiple diagnoses, and then once you have one autoimmune disease, they can travel in pairs or triplets. And that's the phenomenon we're seeing here. But very fascinating. I can't wait to read more about Rosai-Dorfman disease. I don't know much about it. I just know it's usually these weird lymphadenopathy cases, and that's it. So I'm going to learn a lot about it. But thank you so much for presenting this case. So I guess what were your takeaways before we get Amlopreet to teach us?
I think
we were admittedly a little distracted by the lung mass initially when he came in, and also just given the fact that his neuro exam was so unremarkable. And we never really saw the left-sided weakness on our exam. So it wasn't until, the stroke codes that we started, trying to widen our differential beyond just tuberculosis. And our initial thought was, is the mass and the thrombus connected in some ways? Is there like a bacterial infectious process? But what was more intriguing was that this was an arterial thrombus rather than a venous thrombus. His TTE was normal. So I think we had to basically hit him with every test that you can imagine to really capture what was going on here. And I think a while later, we realized that possibly what's going on in the lung and the thrombus are just two unrelated pathologies. And eventually, I think the diagnosis of APLS kind of just came together on its own, but we had to bite the bullet. We had to figure out what that mass was about, and it just had to be biopsy. There was no other way we could put two and two together and figure that out.
Yeah, just to add to that, exactly as you had mentioned, there were so many findings that just happened at such acuity that we were focused on each finding at a time, and it was kind of tough for us to, one, put it all together and also take them individually. And we were so distracted by little things like calcification here or the parotid glands coming in to the picture. It's kind of tough to consolidate it all together. And so, as you had mentioned, it was super helpful to get some of the older records because we needed to know what his baseline was for a lot of these things. And then just the acuity kind of also distracted us because he had to move from one floor to another because of things that were going on in the hospital. So I'm really glad that things worked out the way that he did. He's doing okay now, and that's all that matters.
Actually, more recently, it seems like he's had progressive lymphadenopathy, more so in his cheek. It's getting in the way of, him eating, and I think they're trying to figure out how they want to tackle that. And it also seems like Rosai-Dorfman is often associated with APLS as well. So I think that was just kind of another reason why hydroxychloroquine was something that was added on for him.
Thank you both so much.
Thank you for giving us this opportunity. This has been
Seriously.
really cool to be able to share this case on a wider platform and to really hear you guys talk through your differentials and how you worked through the case. That was a big learning experience.
We learned so much from you today. Thank you.
Thank you so much for this teachings. I think that we all are going to go out from the session and start reading about Rosai-Dorfman and his histostosis and everything. Was such this was a masterclass, and we are very thankful for that. And hopefully more residents from Yale would like to present again another case. Having said that, we have a couple of questions for you. Anyone can answer them. Like, what is something that you like the most from your residency, that when you were choosing Yale as your number one in your ROL, you said, this is the reason why I want to come here?
So I think my opinion was a little bit biased because I did have the chance to come here as a final year med student, and I had the chance to experience the Yale culture and really work here. So as a student, I remember feeling so welcomed, even though I traveled across seas to really be here and have this experience as a student. So I remember feeling extremely welcomed, and I remember feeling like I was a part of the team and really getting some amazing quality education. So just my overall takeaway as a student was something that really stayed with me, and which is why I think Yale was kind of always in the back of my mind, and I always knew that this was going to be a place that I would always think about as number one.
Yeah, kind of similar concept for me. My wife went to medical school here, and so I'd gotten a taste of the culture pretty early, and I'd heard from many people how nice everyone is. But getting to experience it firsthand and getting to see the culture firsthand has just been so affirming that Yale is absolutely the right place for residency for me. And that's it's what brought us here. The fact that Yale has everything that we were looking for a residency in terms of training and in terms of getting the opportunities that we need, but adding on top of that, just the niceness of the people. just goes such a long way in getting you through residency. A huge pull.
It's good to know, definitely, because many times the social aspect of a residency can make or break your experience. And having said that, what is something that you like about the city that you're in? Because sometimes the hospitals can be amazing, but the cities are very difficult to like navigate. What do you like the most?
So go ahead.
Yeah,
I'll
no,
let you answer this one.
I can briefly answer this one because again, my wife went to medical school here, so I've kind of experienced New Haven for quite some time now. And it's actually a really, really good city to do residency, because you get to be close enough to the big cities where you can go any weekend to a big city where we're an hour and a half from New York and 2 hours from Boston. I was actually in New York for dinner on a weekday during a clinic day 4 days ago because we were looking for a reservation for a place and finally got one. And that's the perk of being in New Haven while not having to experience the stress of being in a big city. I live 6 minutes door to door from the hospital. And it's so nice being able to walk home, not having to deal with the traffic or dealing with the costs of being in a big city, but getting to enjoy the luxuries of a big city nearby.
I think I resonate with everything that Ritu just said. I enjoy the fact that I live in a relatively small city, but it has a big city vibe just because of how well connected you are to all the other bigger cities around. And just the experience of living here is it's interesting, and I think it's very diverse, and which are basically my highlights of living in New Haven.
Andrew, do you want to share about your opinion about the program?
I'll just echo, I love the culture here, and that's why I came here too. I think why most residents came here.
And we always receive a question about research. How's the research in the program? If you all have the opportunity to do it, if anyone can answer this one.
It's extremely easy to get involved here in research. I did a little bit of research before I started residency, so it was very easy for me to connect to a new mentor and really find my ground here. But then at the same time, also find another mentor that I liked, whose work I liked, and I thought that his projects were very interesting. So it was honestly as simple as sending him an email and saying, hey, I'm really excited by some of the work that you're doing, and I would really like to get involved. And now I'm involved in a couple of projects with him. And I think my experience is pretty similar to experiences that other residents have had as well. I think it's been fairly easy to reach out to attendings, and it could be someone that maybe you worked with in clinic, or someone you worked with on an inpatient rotation, or even like in my case, someone you've never even met before. Everyone is very open to involving you, and everyone is interested in your academic growth as well. So it's been fairly smooth.
Yeah, I second that. I think it's been so easy to get opportunities here. I feel blessed to be able to say that. I'm interested in oncology, and as soon as people find that out, there are people reaching out with projects because they're looking for residents to join. So been very lucky.
So it's good to know that there are many opportunities to like build all the like what they to apply for fellowship, because I'm guessing that for certain specialties you need quality and quantity research and publications. So it's really important to know that, and we are very happy to have your insights. Having said that, and being very mindful of your time, we will leave the questions until here, because we know that you are still in the hospital and you have lots of things to do. But again, thank you so much. And if you want to present another case, you are more than welcome. It was super fun.
Thank you so much for your time. We really appreciate this experience, and
Absolutely.
hopefully we'll see you again.
Yeah, seriously.
Thank
Thank
you
you
so
so much
much.
for joining us. We learned a ton from the questions that were coming in the chat too about things that we should have thought about or we should have included. So thank you so much for all the participants.
Thank you. It was amazing. Have a great day, everyone.
Thank you.
Thanks,
Bye-bye.
Andrew.
You guys.